أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
My name is Dr. Rizwan. I welcome you all for this international webinar on supramalleolar osteotomy, New Horizons to Explore. So today we have Dr. Zhao from Mumbai Hospital. So he is one of my good colleagues and a good well-wisher of Pakistan. And second, he will be talking in detail about supramalleolar osteotomy. And followed by him will be Dr. Tashin, who will be giving a small example of a case. So Dr. Zhao, kindly, the podium is yours.
Thank you for the invitation to take part in your conference. And the topic Rizwan gave me is supramalleolar osteotomy for the varus ankle osteoarthritis in the myunion. And this procedure is a relatively new procedure for the ankle osteoarthritis. It's a joint preserve procedure. So we search in the PubMed and we can find that it starts from the 1966 and 176 results can found, and mostly in the recent 20 years. Although it's from the 1966, and this procedure is used for the ankle osteoarthritis is beginning from the 1995. After the report by Takakura from Japan, he reported 18 patients use supramalleolar osteotomy just for the ankle osteoarthritis. And after his report, many studies were reported about this procedure in the treatment of ankle OA. So in his study, he reported a classification system about the varus ankle osteoarthritis. And this classification is modified in 2006 by Toneka. And the stage 3 was classified to the 3A and 3B. And in the 176 studies, 3 study is very important to me, I think. This 3 study showed the functional outcome of the procedure, and from this 3 study, we can know this procedure is very useful for the correction of the various ankle osteoarthritis. One is the study reported by Toneka in 2006. His study reported that SMO can reverse the OA stage. We can see the preoperative stage mostly is stage 3A and 3B. And after this procedure, the OA stage was reversed to the stage A and stage 1 and stage 2. So after his report, we can know that this procedure is very useful for the ankle osteoarthritis because he can reverse the stage. And the second study is published in 2015 by another Japanese doctor, Harakuchi. He cleared the relationship between the weight-bearing line and the supramalleolar osteotomy for the various ankle osteoarthritis. In his study, we can see that SMOT can change the weight-bearing line across ankle joint, and the weight-bearing line can be shifted to the laterally. So the stress caused deformity change to the correct of the deformity. This can explain why the stage reversed. And the third study is reported by Korea surgeon Jiang Honggen. He used the arthroscopic technique to evaluate the cartilage of the ankle osteoarthritis. And in his study, we can see that the preoperative cartilage is mostly staged in grade 4. And after the supramalleolar osteotomy, the stage must change to grade 1, grade 2, and grade 3. We can see his case. This patient, in this patient, the talar zoom, we can see the explorer of the subcutaneous bone of talar zoom. But after the supramalleolar osteotomy, the articular surface was fully covered. So these 3 studies are very useful because after we read this study, we have the confidence to do the procedure. And because this procedure is effective for the ankle arthritis. So when you want to do the procedure, you have to clear how to evaluate ankle arthritis. Mostly we use the weight-bearing X-ray of the ankle joint and Solzman wheel. And in these 3 wheel, we can see the distal tibial articular joint angle and the TT angle between the B and line B and line C, and the lateral articular surface angle of the distal tibial articular, and the alignment of the hindfoot. But this is not enough for evaluation. So we have to evaluate clear. For the tibia we have to know the where is the deformity. Is intra-articular or extra-articular? This is an extra-articular, just a virus deformity. And this is an intra-articular. This is very severe and with myonia of the ankle joint. So where is the arthritis location? Just between the metamalleolar space or between the tibia and tibia joint or the lateral side. Also, we have to know the lateral ankle space. The lateral ankle space, just we can see this is the Cochrane joint, and this is open with angles. So this talar moved medially, and the lateral space is very large. So how about the fibula? The fibula, in some cases, the fibula is normal, and in some cases, the fibula change to varus, and some with very severe deformities. So how about the tibial joint? The congruence of the tibial joint is very important for this procedure. And in some patients, the tibial joint is congruence is less than, the TT angle is less than 4 degrees, it's normal. And in some cases, it's larger than 4 degrees. It shows tailor tilt. And in some cases, the deformity is very severe, but the TT joint is normal. So different conditions, we have to use different osteotomy techniques. And also we have to know the change of talus, moved medially or tilt, or moved medially combined with the tilt. In the lateral view, we have to know the spurs location, and in the tibia or the talus, or anterior or the posterior. Also, you have to know the talus in the lateral view. So this is this position is normal, and this talus moved anteriorly, so shows posterior subdislocation of the tibial joint. So this talus moved posteriorly, and the OA location posteriorly. So how about the range of motion of the ankle joint? We have to take a lateral view of the patient with plantar flexion and dorsiflexion. So we can see in some patients, the anterior side is blocked to block the range of motion. So we have to remove those spurs. And the Supramalleolar view, we can see the location of the hard foot and the relation between the tibia and the calcaneus, and about the subtalar joint. So the full length view of the lower limb is also important. In this view, we can evaluate the length of the tibia and the lower limb, and also we can evaluate the relation between the full lower limb. So for the SMOT procedures, they have many techniques. The closed wedge, lateral closed wedge osteotomy, and this is original technique reported by the Takakura. And this is the most used supramalleolar osteotomy lie. This lie is parallel to the distal tibial articular joint, so open it and to correct the varus deformity. And also the oblique osteotomy. The lateral side is just enter the synostosis. Also, they have the intra-articular osteotomy reported by Morrison, and the biplane or the double osteotomy reported by Dr. Hitman. This so many osteotomy techniques used in different conditions. We can see for the lateral closed wedge osteotomy, we must use in the very severe deformities, because for this condition, if you use the open wedge, the medial soft tissue may have some problems. So we use the lateral closed wedge, but lateral closed wedge osteotomy has some problems. As we know, the lower limb may short sometime. We can see this is a galloping, and another galloping marks the osteotomy side and remove of the ostotomy and closed to correct the deformity. And for this procedure, we can see the before the osteotomy, the center of the talus is into the middle of the line of the tibia. So after the osteotomy, it shifted laterally very large. So we have to move the tibia and the fibula and the holy hard folder medially, correct the center of talus to the line of the tibia. So the second is the traditional osteotomy, also the mostly used osteotomy. It's open osteotomy. We can see the line parallel to the distal tibial surface, so open it, and we can see this is 6 years follow-up. The patient is satisfied with the result. So there are some tips. Tip 1 is medial release. Some cases, the medial space is almost closed. The body contact about the medial space, so we have to give a release of the medial, soft tissue, mostly the deltoid ligament. So after release, we give a stress wheel in the intraoperatively, so we can see the medial space is open. For me, I mostly cut the superficial, the anterior superficial of the deltoid ligament and some part of the deep deltoid ligament. Also, in this technique, we may find the fibula bulb. This osteotomy line is finished into the proximal to the syndesmosis. So when you open it, the syndesmosis may block and the fibula may interfere the lateral shift of the talus. So in most of these cases, we have to do the fibula osteotomy. This is our biomechanical studies. We also found the fibula interfere the reduction of the talus. So tip 3 is lateral debridement and repair. When you want to shift the talus to laterally, you have to debridement of the lateral space. We can see have to remove the bony blocks, and after that you have to repair of the lateral ligament or use the broad stroke procedures. The third procedure is oblique osteotomy, reported by Professor Wu Chunli. He used this procedure in the cases with major shift of the talus and the large of the lateral space. For this kind of case, she want to narrow the joint space and shift the talus to the laterally. So he will use stress wheel preoperatively and to evaluate if the middle space can be opened. If can be opened, he will use this procedure, and if not, he will use other procedures. And mostly we will use this the evaluation during operation and after the release of the middle soft tissue. So this is the operation. Intraoperative photos, we can see the operate line. So the galloping and opened bony graft and fixed with plan. We can see this patient. This is preoperative X-ray. We can see the lateral space is open, and after oblique osteotomy, lateral space was restored to normal, and the center of talus shifted laterally. And the hard foot wheel, we can see the line is okay. Look, another case. This case is a bilateral ankle joint pain, and 49 years old female. In the X-ray, we can see the joint is almost normal, just with some various deformity. So we give a minimal invasive operation. And the joint you do not need to give a debridement, so just use a minimal invasive procedure. So give up osteotomy and open and bone graft and fixed with plan. This is 1 year follow-up. We can see the alignment was correctly good, and the patient functions were very satisfied. This is the osteotomy line from the about 5 centimeters proximal from the tip of the middle malleus and to the about 5 millimeters above the joint space, joint surface. So opened it and fixed with a plan. How to protect the lateral cortex? You can use some K-wires before the open range, just used in the lateral side and to protect the lateral cortex to block. If it's broke, it's no problem. So just give fixation of it. But the fourth procedure is the intra-articular osteotomy, introduced by Mark Myerson in 2003. He reported that some of the various ankle osteoarthritis cora is just intra-articular, so the articular surface is not good. You have to correct from the cora side. So the intra-articular osteotomy was introduced. We can see this case, a bilateral varus ankle osteoarthritis. The lateral side is much severe but have no symptoms, so he want to correct the right side. The right side we can see is intra-articular, some intra-articular deformity, and the red motion give a protection of the articular surface and the guide pin of the osteotomy. And the intraoperative photos, we can see we opened it. Yes, the articular surface was correct, good. So we give a bone graft and fixed with a plan. This is 1 year follow-up. The patient was satisfied with the results and the alignment restored to the normal. This is the osteotomy site. So you have to osteotomy just finish into the tip of the deformity, the cora side, and open it. So for some patients, the osteotomy may break into the articular surface. It's no problem. So remove the K-wires and reduction of the osteotomy and fixed with the screws is okay. So we can see this case. This is intra-articular deformity, and I will give an intra-articular osteotomy, and this is the X-ray post-operation. And the 1 year follow-up, we can see the joint is okay, but the center of talus is still in the medial side of tibia. So if we use double osteotomy and intra-articular osteotomy combined plus supramalleolar osteotomy, maybe the correct will be better. So 2017, Dr. Hitman introduced double osteotomy technique for the varus ankle osteoarthritis. He reported that, and firstly he agreed with Dr. Marson that some deformity is intra-articular, so he corrected the intra-articular deformity. And after the intra-articular deformity, the center of talus is still in the medial side of the tibia, and he plus supramalleolar osteotomy. And the center of talus was corrected for the laterally. So this is his case. We can see this case is not so much severe, but he used double osteotomy. And this is X-ray post-operation. We can see one of my case, a 48-year-old male with varus ankle osteoarthritis. We can see a severe varus of the ankle and hide foot joint, or hide foot. From the X-ray, we can see the deformity is intra-articular, and with some spurs and the varus of the hide foot. So firstly, we give a lateral debridement and an intra-articular osteotomy and opened it. Evaluated, we found that the talus was not was blocked by the fibula, and the lateral space is closed. So we have to give a fibula osteotomy. A fibula closed osteotomy was made in the further open of the intra-articular osteotomy site. We can see that the joint is okay, but is still with some varus deformity, and the center of talus is still in the middle of tibia. So we give a supramalleolar osteotomy. We can see intraarticular and supramalleolus. So after that, we can see the joint space is corrected very good. So the preoperative view, the intraoperative view, and the postoperative view. And after 6 months follow-up, we can see the the alignment is corrected very good, and the center of talus corrected to the laterally. So this is another case, also an intraarticular deformity, and with varus of the harder foot and some kind of cavernous foot, yes. So the talus moved anteriorly. We give a lateral debridement in the intraarticular osteotomy and the supramalleolar osteotomy. We can see. And this is the follow-up time. Yeah, the talus was corrected to normal position, and also the center of talus shifted posteriorly, and the hard foot is corrected very good. So this is the osteotomy line of the double osteotomy technique. One is to the intraarticular deformity, and the other supramalleolar. In most of these cases, the fibula have to be osteoped. For the supramalleolar osteotomy, the correction of the talar tout is where most debated, as time is limited. So some reported 17.3, some reported 10. Larger than these degrees cannot be corrected by supramalleolar osteotomy. So in our cases, we found that disjunction is a very good procedure, can correct the talar tout. So we used in the supramalleolar cases. We can see this case, very large talar tout and the supramalleolar osteotomy plus medial disjunction. And 3 years follow-up, we can see the joint congruence is very good. And the CT scan, we can see the medial space is open and the function is good. Another case, the talar tout, osteotomy, and disjunction. And 1 year follow-up, the medial space is open. The alignment is good. So we can see the hard foot also corrected to normal, and so we use the medial disjunction in our cases with talar tout and corrected very fine. So for the correction of talar tout, you can use the medial soft tissue release, the lateral repair or the reconstruction, or the fibular osteotomy, or the calcaneal osteotomy. Also, the medial disjunction is a very good technique for correct of the talar tout. For about the fibular osteotomy, some cases reported used in all of the cases, and some not used the fibular osteotomy in all cases, and some reported depending on the conditions. For the fibular osteotomy, they have many techniques. We concluded that for the fibular osteotomy, we use at about the same level of the tibial osteotomy. So you can use oblique osteotomy or a closed wedge osteotomy. If used in the oblique osteotomy of the tibia, you can use the distal osteotomy of the fibula. We see one case. This patient is a varus deformity, and we not use the fibular osteotomy. And after 2 years follow-up, we found that the syndesmosis space was enlarged, and the lateral space was closed and have some block. And the patient has symptoms at the lateral side. And this is another case, the medial symptoms, and we used osteotomy. And about 1.5 years follow-up, we can see that the talar shift laterally, and the See that Moses was open and the lateral ankle joint was closed and some impingement. So the patient felt pain of the lateral side. So the indication of the fibular osteotomy, if the patient with various change olfactory myonia or increase of tail culture, or have the difficulty in reduction of talus, or the original supramalleolar osteotomy, if you use this technique, mostly patient need the fibular osteotomy. So the supramalleolar osteotomy with external fixator. If the patient with large deformity, if you and some short of the lower limb, you use the medial open, the may have some problem with the medial soft tissue. If you use lateral closed wedge, that will further short of the lower limb. So we used osteotomy and distraction with the axial fixator. We can see this patient 6 months and 12 days, the patient come back to remove the external fixator. He can move back. So after about 2 years post-operatively, the alignment correct very good, and the range of motion is normal. We can see the lungs, the alignment, the joint coherence is very good. So this is reported by Dr. Hitman in 2018 AOFAS meeting conference. He evaluated 586 supramalleolar osteotomy cases and with 16 years follow-up. So 473 survived. The failure rate about 23.8%. The mostly failure in the first 2 years. And we can see his case. He used the supramalleolar osteotomy in very severe conditions. This is a penile functor myonia, and the joint the joint have fused. So he used the osteotomy and 4 years follow-up with 19 point of the AOFA scores and no pain and range of motion about 14 degrees and no limitation spots. So we see one of our case. This is a 15 years old male and end-stage ankle osteoarthritis, very severe. If you use TTC fusion, is very good, but he want to protect his motion. So we give a simple debridement and supramalleolar osteotomy. And after 6 years follow-up, we can see the patient is satisfied with the results. The joint space is not normal, but it's okay. We can see pre-operative and 6 years post-operative. The patient is satisfied by the results. So I give a conclusion. The joint preserve procedure is gradually accepted. Supramalleolar osteotomy can change the weight-bearing line of the lower limb and improve the functional and radiological outcomes. However, the osteotomy is not just a simple procedure. We have to evaluate carefully and choose the best way. But this is very difficult. So we have a long learning curve. And also you have to plus some other bony or soft tissue balance procedure to achieve good results. Okay, thank you.
Thank you, Dr. Zhao. That was a very good presentation. It is my pleasure to inform you that we have got a few of our Pakistani Institute of faculty joining the webinar. Dr. Harun, Dr. Masood, Dr. Mohsin Azam from Dubai, and Dr. Sikandar Hayat as well. We have been doing supramalleolar osteotomy for other reasons than ankle osteoarthritis, and mostly the correction are done by Elizabeth. So just to inform you, Dr. Zhao has got a few publications regarding supramalleolar osteotomy, Journal of Foot and Ankle Surgery. And if you would like to go through it, it would be great for increasing the knowledge. So, a small case presentation by Dr. Tashil. Dr. Tashil.
Assalamu alaikum and hello everyone. Welcome to Dr. Hongmo Jao. Good to see you again and good to listen to your talk. You have an extensive experience of such osteotomies and I really enjoyed your talk. It was very enlightening. I have a case that I be prepared for this presentation that I would like to show you, and it would be great to have your comments on. Yes, so this was a 48-year-old male who had an injury in the childhood at the age of around 6 years. It was an open injury to the ankle, and he underwent multiple surgical procedures at that time, but with the eventual healing of the wounds. But with growth, he developed a deformity of the ankle with a varus deformity. And he spent his adulthood essentially with that varus deformity, but he was fully functional. But now he started to develop pain on prolonged walking, mostly located over the anteromedial aspect of the ankle. So on examination, his heel was in varus, but there was good movement of both the ankle and subtalar joints, and no gross crepitus could be elicited. Sorry, I wasn't able to get good pictures, but this is one of the pictures that we have. We can see the varus of the hindfoot. This is what the X-rays showed. The one on the left, the AP view shows the degree of varus. This is a standing X-ray. What we see is not only just the tibia deformed in the distal part leading to the varus, but also narrowing of the joint space over the over the medial gutter, indicating asymmetric cartilage thinning. On the lateral X-ray, we can see some osteophytes anteriorly and posteriorly, and because of the fact that there is a varus tilt, we cannot very clearly see the curvature of the dome symmetrically, because the two, the medial and the lateral parts of the talar dome are at different levels. The mortise view again shows us the asymmetric deformity. So this patient had apparently a growth arrest of the medial aspect of the tibia, leading to the varus deformity. The Saltzman view shows on the opposite side, the left side, we see parallel tibial axis and the calcaneal axis, while gross varus tilt is observed over the right side. The MRI scan shows these osteochondral lesions over both the medial and the lateral parts of the dome, and a corresponding lesion over the distal tibial plafond. But there was no unstable lesion as such. So these were representative of the asymmetrical loading over the medial gutter due to the varus deformity. So we decided that this patient has early ankle arthritis, but his thickness of his cartilage was quite good. So we decided to salvage his ankle and offer him correction of the underlying problem which was leading to the arthritis, which was the varus deformity of the tibia. Now, the thing is that the cora in this case is at the level of the joint line. Doing a osteotomy, opening wedge or a closing wedge at a level, for example, higher at this level. Let me see if I can make some lines with this pen. Yeah. If we do an osteotomy at this level, an opening wedge, for example, we thought that that would lead to lateral translation of the distal of the joint, which would be undesirable. And if we bring the osteotomy much down closer to the joint line, then the syndesmosis would be affected, and we did not know how if it was a good idea to violate the syndesmosis. So what we decided was to do a dome osteotomy instead, which was this. So with the cora at the ankle joint line, we just drew a curve around that cora, which gave us this kind of a plane for the osteotomy. and with a corresponding oblique cut over the fibula, which was you can even this arc can actually go across like this along the fibula also. So with this our cora being the center of this curve, so with that we were able to achieve rotation of the distal fragment without any mediolateral translation, and ensuring that the long axis of the tibia corresponds to the center of the ankle joint roughly. So this was our post-op results. As you can see, we have achieved almost horizontal ankle, and we fixed it with a locking plate. The center of the ankle joint is in line with the center of the tibia. Sorry for my wavy line, but it's in the same line. So we have only about 3-month follow-up on this patient. He then left the country. So we are waiting for further reports from him. But as of last, he was able to walk without any pain. We were still advising him to use a walking boot, and he had no symptoms while walking. Thank you.
Thank you, Dr. Tashrin, for such a good case. So now I would like Dr. Rao to shed some light on the case presented, and would like the audience to have, if they have any questions, they could ask Dr. Rao as well.
Yes, I think this procedure very, very good. For this case, just reported by Tarfi, I think for this severe varus deformity, if the patient come to me, I will choose the dome osteotomy just reported by Tarfi, or I will use external fixator. So give because this patient is injury just in 6 years old, so maybe this patient has some short of the lower limb. So the dome osteotomy is a very good procedure, I think. If you use the medial open, the soft tissue may have some problem. If you use a closed wedge, they may further short of the tibia. So for me, my first choice also will be the dome osteotomy. I think it's very good.
Thank you. And this patient did not have any leg length discrepancy. The measurements over the lateral aspect were symmetrical on both sides. Medial side was short, yes, but it did not really. If there was no need for lengthening, because at the center of the ankle level there was no shortening. So you're right. That is one of the reasons why we also chose not to apply an external fixator. We have a very good elixir of service in our hospital. I did discuss this with our elixir of surgeon and showed him my planning, and he also agreed that this dome osteotomy would work well for him. Thank you.
Thank you, Dr. Dashmin. Thank you, Dr. Zhao. So any questions from the participants? I will like Dr. Haroon to share some of his views regarding the topic and the talk by Dr. Zhao. Dr. Haroon?
Yeah, thank you, Dr. Rizwan. It was really a wonderful information I got, and I really enjoyed it. Then thank you very much to our Chinese colleague. I'm sorry, I cannot, I do not know how his name is pronounced anyhow. But yeah, very impressive, and Dr. Tashwin case was also excellent. So dome osteotomy, yes, is most of the time our favorite procedure too. So thank you, Rizwan, also for organizing this excellent seminar on focusing on single topic. Thank you.
Thank you, Dr. Haroon. So, Saad, any questions, or we should conclude the session?
Sir, there is a question. What about the osteochondral lesion? Will they heal? A question from Dr. Kilam.
Yeah. Okay, Dr. Zhao, there is a question for you from the. So the participant is asking that with this kind of varus deformity, there could be osteochondral defect, OCD of the talus. So how do you tackle this OCD of the talus?
I know. For me, if the patient have some OCD, if it's severe, I will do the intra-articular osteotomy and give no, for this patient I will do nothing. I will do nothing about the OCD. So if it's large, I will do some procedure to correct or the
Autograft or some drilling of the OCD. That's what you are trying to say, I guess.
and this patient the OCD is not severe. I think you do not need to take care of that. So just leave it, and the supramalleolar osteotomy is enough. If you with large injury, I think they have two problems: the varus ankle osteoarthritis or the OCD. If the two conditions in one patient, I will use intra-articular osteotomy and plus osteochondral transfer to take of that.
Thank you, Dr. Zhao, for such a kind lecture.
You're welcome.
So, inshallah, we will be seeing you in Pakistan soon after the corona pandemic is over. Thank you, Dr. Tashween, for a case presentation at last notice which I gave you. Thank you for always supporting this educational activity. And I would like to conclude this session. Thank you, Dr. Zhao. Thank you, all the participants. Take care. Have a good night. Thank you.